Good morning. Everybody have a good time the weekend? You all relaxed? Okay. Let's back to reality. And I'm still Dr. McConnell, and I'm still talking about the thyroid, and I still don't get paid for these lectures, so I have no conflict of interests. However, there is a tip jar in the lobby as you're on your way out. The learning objectives. By the end of this lecture, you should be able to identify the clinical characteristics common to patients with Graves' disease, including those with thyroid eye disease. Should be able to detail the various therapies for hyperthyroidism and the relationship to normal thyroid physiology, and describe the presentations of patients with primary hypothyroidism. That's destruction of the thyroid. And finally, you should be familiar with replacement therapies available for the treatment of hypothyroidism. Start with the case. It's a lady, age 20, became affected with some symptoms which were supposed to be hysterical. Her pulse had become singularly rapid. She complained of weakness on exertion and began to look pale and thin. It was observed that the eyes assumed a singular appearance, for the eyeballs were apparently enlarged, and in a few months, a tumor of horseshoe shape appeared on the front of the throat and exactly in the situation of the thyroid gland. Absolutely classic. Dr. Robert J. Graves, 1835. This is what Dr. Graves looked like about the time that he described that disorder, and this is apparently what his patient looked like. Now, Graves' disease, also known as toxic diffuse goiter, is the most common cause of hyperthyroidism, thyroid overactivity. It's a disorder typically of young women of your demographic. It's about 5 times as common in women as in men. Peak age incidence in the 20s and the 30s. Has 3 cardinal manifestations. Number 1 is a symmetrically enlarged thyroid gland, the toxic goiter that's seen in virtually 100% of patients. Secondly, you have thyroid eye disease, which is seen in about 40% of patients. Now, the thyroid eye disease is a closely related autoimmune disorder that's not due to excess thyroid hormone. You get that in your head. It's not due to excess thyroid hormone. It's a separate autoimmune disorder, very closely related to the toxic goiter. One caveat that you should know. The periorbital swelling, it's called periorbital edema, and the protuberance of his right eye, it's called prooptosis, are part of the autoimmune process. However, this retraction of the upper lid, this deer in the headlight looks, is due to the excess thyroid hormones, due to increase in alpha tone of the upper lid. That's due not to an autoimmune disorder, but to excess thyroid hormone, whereas the swelling and the prooptosis are autoimmune, and we're going to get back to that in a few minutes. About 5% of patients with Graves, yeah, that's pretty impressive. That's pretibial myxedema. That's as classic as you'll see it. It's about 5% of patients with Graves will have the pretibial myxedema, typically the patients who have the thyroid eye disease. This is also a separate autoimmune process. It's not due to excess thyroid hormone. So giving a patient high doses of thyroid hormone or a patient who has a non-autoimmune hyperthyroid condition such as toxic adenoma or toxic multinodular goiter, they won't get it. Only in Graves. Elderly patients lack the typical hyperkinetic signs and symptoms of the younger people your age. This is known as apathetic thyrotoxicosis. Its typical presentation: weakness, unexplained weight loss. And when you're working patients up for unexplained weight loss, you'll do screening tests for hyperthyroidism. Of course, the best screening test is the TSH, right? Okay. So weakness, weight loss, and a cardiovascular manifestation are very common. And the cardiovascular manifestations are angina pectoris, a tachyarrhythmia, such as atrial fibrillation, that's the classic one, or congestive heart failure. So they're going to present with weight loss or cardiac manifestation. Now, Graves' disease, like other thyroid disorders, typically runs in families with the kids inheriting a predisposition to the disorder from their parents. But it's widely recognized that not every family member is involved, and there are environmental factors which are important in the genesis of Graves' disease. Some of the more important: psychological stress, which is manifested by this young man's severe retro look; pregnancy, and that's probably what Marcia in this episode is announcing; or cigarette smoking. Now, Graves' disease is an autoimmune disorder that's caused by an IgG directed against the TSH receptor, called the TSH receptor antibody. Now, the TSH receptor is a funky little receptor that's rather promiscuous. It interacts not only with TSH under normal circumstances, but with the stimulatory immunoglobulin, the etiologic agent of Graves' disease, and also, as I told you on Friday, HCG in high doses, in high levels, can stimulate the TSH receptor. Now, not only do these stimulatory immunoglobulins cause an increase in thyroid hormone production, but they also cause the thyroid gland to enlarge. This is a radioiodine scan of a normal-sized thyroid gland, and over here on the right is the radioiodine scan of the young man of 5 slides ago with the Graves' disease. You can see that the thyroid gland has grown in size. And this thyroid gland is maybe 3 or 4 times normal size. So this is the picture of the toxic diffuse goiter. This is as bad as it gets. I know, I always get this reaction, but you'll remember it. This is probably one of the worst cases of thyroid eye disease that I've ever seen. Actually, this guy got better. He was cured of his thyroid eye disease. He was cured of his toxic goiter. And he died of myasthenia gravis, another autoimmune disorder. These autoimmune disorders typically run in packs, and someone who has Graves' disease has an increased risk, albeit small, of developing another autoimmune disorder. He has swelling around his eyes, the periorbital edema, and he has this heaped up conjunctiva. It's known as chemosis. Chemosis. Also, his left eye is protuberant. You can't see it there, but it is protuberant. Up. Did I go off the air? What did I do? Oh, it's okay. One time I pressed a button, the audience disappeared. Okay. You'll notice something about this patient. He's not a young woman. He's an older man. And we'll get to that in just a few minutes. So remember this. It's an older man. This is the orbital CT scan of the last patient. What you're doing is looking at it from the bottom. This is his left. This is his right eye. There's an expansion of the retroorbital space in the left compared to the right eye. And that expansion of the retroorbital space, because it's a bony box of the orbit, it's forcing the globe forward. And this leads to the proaptosis. There also is decrease in venous outflow because of the expansion of the retroorbital space. And this causes the heaped up conjunctivae, which are very nicely shown there. That's the chemosis. And what you may not appreciate, and you really can't tell on this cut, is that his optic nerve is impinged upon. And he was going blind because of impingement on the optic nerve. The extraocular muscle, this is the medial rectus, is really plump and juicy. Now, typically on a CT, you're not going to see the extraocular muscles. But in the case of thyroid eye disease, they swell. Also, the swelling of the retroorbital space is due to several factors. The cause of the thyroid eye disease is due to expression of the TSH receptor on retroorbital fibroblasts. What the TSH receptor is doing being expressed on retroorbital fibroblasts, I have to leave to someone in this audience to figure out someday maybe. The expression of the TSH receptor on the retroorbital fibroblasts attracts the immune system. And lymphocytes come in, secrete cytokines, and this cytokine activation leads to proliferation. They proliferate. They increase glycosaminoglycan production, especially high L-uronic acid. And you may recall from somebody else's lecture that glycosaminoglycans are very hydrophilic, little sponges, pull in the water. And this water leads to the part of the expansion. And lastly, the fibroblasts differentiate into preadipocytes. So there's an expansion of retroorbital fat. So you get the proliferation of fibroblasts, glycosaminoglycan production, and the expansion of the retroorbital fat that leads to the proaptosis. The epidemiology of thyroid eye disease is different from that of Graves. The toxic diffuse goiter, female to male ratio of about 5:1, peak age incidence in the 20s and 30s. Whereas the thyroid eye disease, seen in about 40% of patients with toxic diffuse goiter, has a much lower female to male ratio. Instead of being 5:1, it's about 2:1. And its peak age incidence is shifted to older age groups. It peaks in the 40s and 50s. The biggest risk factor for thyroid eye disease is cigarette smoking. Current smokers are about 8 times the risk of developing thyroid eye disease as non-smokers with Graves' disease. There also is intriguing epidemiologic evidence of an association between radioactive iodine therapy, the most common treatment for Graves' disease, and exacerbation of thyroid eye disease. Now, what causes that is really unclear, but it's a common observation that patients who have active thyroid eye disease will show progression of their thyroid eye disease after radioactive iodine therapy. Whereas patients who don't have any clinical manifestations of thyroid eye disease won't progress. They won't develop it, they won't progress. But patients with established disease get worse. Now, let's shift over into the therapy of hyperthyroidism. What goals? First off, we're going to be decreasing the circulating levels of the thyroid hormones, either through destruction of thyroid tissue, radioactive iodine or surgery, or pharmacologic means that reduce the synthesis and release of T4 and T3 and or reduce the peripheral conversion of T4 to T3. And T3, of course, is 3 to 4 times as active as T4, so it's the metabolically more active hormone. I want to get T3 levels down really quickly. To make the patients feel better, we also like to ameliorate the symptoms of hyperthyroid state. And something we're not so good at is to correct the underlying pathophysiologic process. That we really are not good at. Thyroid hormone biosynthesis. It's a slide that you saw Friday. Thyroid hormone biosynthesis is a 3-step process. Number 1, you have iodine transport by the sodium iodine symporter. Number 2, you have oxidation, organification, and coupling by the thyroperoxidase. And thirdly, you have the proteolysis, release, and dehalogenation. Every one of these unique steps has its own unique inhibitor. Iodine transport, the rate-limiting step in thyroid hormone biosynthesis, can be inhibited competitively by thiocyanate and perchlorate. Thiocyanate is probably the more important one. It is a naturally occurring substance that can potentiate environmental iodine deficiency. So it's more important in those parts of the world that are iodine deficient. The perchlorate is a niche player in treating hyperthyroidism, and is typically reserved for treatment of hyperthyroidism due to the antiarrhythmic amiodarone. So last week I told you amiodarone decreases T4 to T3 conversion, peripheral tissues by inhibition of the type 1 monodeiodinase. It also can cause hyperthyroidism, and it may be treated with, what do I keep doing here?
Anytime you hit this one, it'll turn it off.
Which one? Okay.
So the blank one, so then you just hit the one.
Oh, okay. Sweet. Thank you. The major antithyroid medications are known as the thyrourines, or more, that's British terminology. The American terminology is the thioureas. 2 major thioureas we're going to be talking about in a few minutes. The thioureas are inhibitors of the thyroperoxidase, the enzyme responsible for oxidation, organification, and coupling. It's important therapeutically to remember that this is a delayed effect, that they inhibit thyroid hormone, inhibit the synthesis of new thyroid hormone, but they have no effect on the amount of preformed thyroid hormone within the gland. So it takes several weeks for a patient put on a thiourea to bring down their thyroid hormone levels to normal. So it's a delayed effect. 2 major thioureas, propylthiouracil and methimazole. Heterocyclic compounds, both containing thiourea group. There's a thiourea group in PTU and a thiourea group in methimazole. What are the mechanisms of action of the thioureas? Intrathyroidally, they inhibit the incorporation of iodine into tyrosine, so they inhibit organification. They also inhibit the coupling of the monoiodotyrosine and diiodotyrosine to form T3 and T4, and they do this by interfering with the action of the thyroperoxidase. They also have extrathyroidal actions. It's an interesting observation that they reduce the titers of the thyroid-stimulating immunoglobulins. And so in some way they may be correcting the underlying pathophysiologic state, but it's really unclear how it does this. Apparently by decreasing thyroid hormone production, there's a decreased signaling of the thyroid follicular cells to the immune system, and thyroid-stimulated immunoglobulin levels fall. They also, PTU in high doses, industrial megadoses, can reduce the conversion of T4 to T3 through inhibition of the type 1 iodothyronine deiodinase, primarily in the liver and skeletal muscle. And so patients treated with high doses of PTU, T3 levels fall faster. This leads to some therapeutic advantage of treating patients with severe thyroid overactivity with PTU. Now, this severe thyroid overactivity, life-threatening disorder, it's known as thyroid storm. Here's a head-to-head comparison of the pharmacokinetics of the two thioureas. They both have a similar absorption peak from the gut, and they're both concentrated in the thyroid. But look here. The half-time of methimazole in the circulation is roughly 4 times that of PTU, and the duration of action of a single dose is twice as long. Now, this confers an advantage on methimazole because you can get away with treating the patient with a single daily dose. I don't know how many of you have tried to take 2 or 3 pills a day, but I have, and I can never remember it. And you get much higher compliance rates by treating the patient with a single daily dose of methimazole as opposed to PTU. Now, this prolonged half-time in the circulation and prolonged duration of action to inhibit thyroid hormone biosynthesis happens despite very little protein binding of methimazole and a much lower starting dose. You see, the starting dose for methimazole is about 1/15 that of propylthiouracil. The uses of propylthiouracil in methimazole and hyperthyroidism, they may be used either as primary therapy for Graves' disease or in preparation more commonly for definitive treatment with either radioactive iodine or surgery. The statistics are that in the United States, somewhere about 75 to 80% of patients with Graves' disease will end up taking radioactive iodine. Maybe 2 or 3% will have surgery. We'll talk about that in a few minutes. And the rest will take the anti-thyroid medication. Now, as primary therapy for Graves' disease, only for Graves' disease is thiourea as primary therapy, not for the non-autoimmune causes of hyperthyroidism. It's not primary therapy for toxic adenoma. It's not primary therapy for toxic multinodular goiter. Only for Graves' disease, only for the autoimmune disorder, because in some way the thioureas modulate the immune response. Practically, when you have a patient on the thiourea, you adjust the dose every 2 to 3 months to keep circulating thyroid levels within the normal range. And the usual course of therapy can be as short as 6 months or up to about 18 months. Now, why 18 months? It's because of the observation that patients who do not go into a remission with normal levels of circulating thyroid hormones and TSH, by the 18-month period, won't. They just won't. It means they're very resistant. So 18 months and out. The remission rate is significant but quite variable. At most, 50% of patients will have a long-term, long-duration remission. And that's shown on the next slide. Here you have percent of patients remaining in remission months after end of treatment of Graves' disease with an anti-thyroid medication. Somewhere around 1/4 of patients who are in remission stop the thiourea, they'll relapse within the first 6 months, which means that 75% of patients are left in remission. After 12 months, somewhere around a third of patients will relapse. So 66% or so of patients will remain in remission. And when you follow the curve out here to 48 months, 4 years, you find that at most 50% of patients will have a durable remission, which means that the other 50% of patients have relapsed, means they go back on a thiourea, or more commonly, they'll opt for definitive therapy with radioactive iodine. The thioureas are also used in preparation for definitive treatment with radioactive iodine surgery. By decreasing the amount of preformed thyroid hormone, you blunt the release of thyroid hormone release after radioactive iodide therapy. Dropping the atomic cocktail of radioactive iodide into the thyroid gland leads to cell death, necrosis, release of preformed thyroid hormone. And thyroid hormone levels will go up starting about a week out after administering the radioactive iodide, peak at about 2 weeks, and then gradually come down. Now, this rise in thyroid hormone levels can lead to an exacerbation of the hypothyroid state in people who aren't prepared properly to decrease the amount of preformed hormone in the gland. For you guys, it doesn't matter. So you get a little bit more thyrotoxic, you get a little bit more anxious, you get some palpitations, maybe you get some initial insomnia. But for old guys like me, it matters because who knows? You know, may have a little coronary artery disease, could set off atrial fibrillation. So basically, younger people we're a little bit more liberal, but certainly patients over the age of 50, we pre-treat with thioureas before administering radioactive iodine. The pre-treatment with thioureas also reduces the risk associated with surgery on an untreated hyperthyroid patient. Manipulating the thyroid gland releases thyroid hormone. And so a patient who goes to surgery is pre-treated with thioureas to reduce the amount of preformed hormone in the gland and reduce the release into the circulation. Before Emil Kocher, back in the 1880s, perfected the thyroidectomy, the mortality rate of thyroidectomy for Graves' disease was 75%. And remember, this is mostly young women, young, healthy women, largely because of release of the excess thyroid hormone. There are certain side effects of the thioureas. A transient decrease in the white blood cell count, which is not a harbinger of agranulocytosis, occurs very commonly. Up to about 25% of patients will get a leukopenia. And a practical point is that a baseline CBC with white blood cell count is strongly advised before starting the thiourea. Skin rashes occur in about 10% of patients. Liver dysfunction, this is really very important. It happens in maybe 6%. Propylthiouracil, fairly recently, has been shown to cause hepatocellular necrosis, which is quite severe in about 0.1% of patients. And this especially it happens in younger children and adolescents. This hepatocellular necrosis has led the FDA to issue what's called a black box warning. In the physician's desk reference. Basically, it's in bold black print, big letters, so you can't miss it. That indicates a severe toxicity potential. Methimazole causes a cholestatic jaundice in 5 or 6% of patients, which by and large is reversible. It doesn't lead to hepatocellular necrosis. Arthralgias can happen, 5%. And this is one of the more feared ones, agranulocytosis, which typically is front-loaded, occurs within the first 3 months of therapy, and occurs maybe in 0.5% of patients who take thioureas. Iodine is the most important inhibitor of the proteolysis release and dehalogenation step in thyroid hormone biosynthesis. It's an immediate effect. So if you give a patient a saturated dose of potassium iodine within a couple of hours, maybe even less, maybe within an hour or so, it'll be absorbed and block the egress of thyroid hormone from the thyroid gland. So it's immediate effect. And a way to remember this is iodine is immediate, but thioureas take time. So thioureas take several weeks, iodine is immediate within a matter of hours. The use of iodine in treatment, it blocks secretion of the preformed hormone, and it's very useful in acute situations where rapid control is essential, such as severe case of hyperthyroidism, thyroid storm. You use the iodine in conjunction with the thioureas, typically propylthiouracil. Iodine also reduces the vascularity of the thyroid gland and is essential for reducing the amount of bleeding. A thyroid is well endowed with blood vessels, and bleeding uncontrolled bleeding was one of the causes of mortality in the early thyroidectomy cases that Coker perfected a way to decrease the amount of bleeding. Today we use iodines to decrease the vascularity of the gland. Like iodine, lithium blocks the secretion of preformed hormone from the thyroid gland. There's an increase in radioactive iodine retention after administration of a therapeutic dose and prompter control of hyperthyroidism. Now, iodine is preferred to lithium, but there are some patients who get or have allergic reactions to iodine, and in those cases, if we need to, we use lithium. Symptomatic relief of hyperthyroidism. Beta-adrenergic agonists and calcium channel blockers. The beta-adrenergic agonists alleviate many of the hyperadrenergic symptoms of hyperthyroidism, such as anxiety, the tremor, and the heart palpitations, decreases the heart rate. Also can decrease the stare that can happen in some patients who have too much thyroid hormone. And propranolol, interestingly, reduces the peripheral conversion of T4 to T3. It has some effect to decrease the type 1 iodothyronine deiodinase activity. Calcium channel blockers are used in those patients who can't tolerate beta blockers or when beta blockers are contraindicated, such as patients with reversible obstructive airway disease or asthma. Radioactive iodine. So antithyroid drugs, I mean, they're really good as long as they take them, but the remission rate is only in the 40 to 50% range. Radioactive iodine, 75–80% of patients in the United States will end up taking radioactive iodine. The Europeans and the Asians don't use radioactive iodine as much as we do. They tend to use long-term thioureas or thyroidectomy. Radioactive iodine is very effective. The therapeutic endpoint is basically you kill the thyroid. So you give enough radioactive iodine to kill the thyroid. And in doing so, there are certain concerns. First off, that there may be a teratogenicity or long-term genetic damage. That has not been shown to be the case. It doesn't cause long-term genetic damage. Of course, you never give radioactive iodine, at least knowingly, to a pregnant woman. So they all get a pregnancy test. Neoplasia, in general, No, it doesn't cause neoplasia. And also, it doesn't cause thyroid cancer. And actually, it may decrease the risk of thyroid cancer by killing thyrocytes. So if you get dead thyrocytes, they're not going to mutate into cancer. Another concern, a possible concern, do they cause infertility? No, they don't. They don't cause infertility. So you can tell your patients that they will be as fertile as they would be under any other circumstances. Hypothyroidism is the expected therapeutic endpoint. So patients are told they will become hypothyroid. And of course, they have to go on long-term thyroid hormone. Now, think this through. What you're doing is you're trading in one disorder, hyperthyroidism, for another disorder, hypothyroidism. Okay. However, it's widely recognized that using thyroid hormone for a patient's lifetime is cheaper, safer, simpler than using the thioureas. Thioureas do have side effects, whereas thyroid hormone does not when used in proper doses. Exacerbation of thyroid eye disease. There's something, though, that as I've already mentioned, can happen. That patients who have Graves' disease and active thyroid eye disease can have an exacerbation after radioactive iodine therapy. So in these patients, we either use long-term thiourea or we send the patient to surgery. Those with active eye disease. Some patients, if thioureas don't work out or the patient has some sort of an excess surgical risk, then we put the patient on long-term glucocorticoids after the radioactive iodine for several months to decrease the risk of flare of the eye disease. Surgery is the oldest form of therapy. Dates back to the 1870s, right after the Civil War, American Civil War. But it's really used selectively now for treatment of Graves' disease. And it's reserved for special circumstances. Number one, a pregnant woman who fails antithyroid drugs. So even high-dose antithyroid drugs don't keep her euthyroid. Of course, you're not going to give this woman radioactive iodine, so we opt for surgery typically in the second trimester. Patients with active eye disease also are candidates for surgery if antithyroid drug doesn't work out. And finally, some patients in whom there is an increased suspicion of cancer. Certain risks are associated because of contiguous structures. Recurrent laryngeal nerve damage occurs in maybe 1% of patients who have thyroidectomy for Graves' disease, and another 1% will become permanently hypoparathyroid, either because of removal of the parathyroid tissue or devascularization of the parathyroid glands at the time of surgery. It happens in 1%. So maybe the cumulative morbidity is in the 1 to 2% range after total thyroidectomy. Of course, radioactive iodine doesn't cause either one, doesn't cause recurrent laryngeal nerve damage, doesn't cause hypoparathyroidism. And hypothyroidism, of course, is the expected therapeutic outcome. Surgeon will take out enough thyroid tissue to render the patient hypothyroid because she doesn't want to go back in and have to do a second operation, which increases the morbidity. Here's Our Lady of the hypothyroidism, primary hypothyroidism. Primary hypothyroidism, typically a disorder of middle-aged to older women. Your mother's demographic. It's about 8 times as common in women as in men. Peak age incidence in the 50s to 60s. And this is the typical appearance, this rather dull, apathetic appearance. There's a certain puffiness to her face due to widespread deposition of hydrophilic glucosaminoglycans, the GAGs. Now, here's a semantic. problem. The total body deposition of these GAG proteins is known as myxedema. That's total body. And in fact, myxedema is a synonym for primary hypothyroidism. That you may see that it used synonymously. Whereas localized myxedema in the pretibial region is only seen in Graves' disease. So pretibial myxedema, Graves, total body myxedema, primary hypothyroidism. The causes of primary hypothyroidism: autoimmune, iatrogenic, pretty much 50-50. So 50% autoimmune, 50% you guys are going to be causing the patient to become hypothyroid. Hashimoto's disease, also known as chronic autoimmune or chronic lymphocytic thyroiditis. It occurs fairly commonly. Depending how it's defined, affects upwards to 14 or 15 million people in the United States, which is roughly the population of New York State. Interestingly, the natural history of Graves' disease. Studies, large studies, have shown that upwards to 25% of patients who are in a long-term remission after anti-thyroid drug will eventually burn out and become hypothyroid. So this autoimmune process will eventually burn itself out. And one thing you should know is that Graves' disease, toxic diffuse goiter, and autoimmune thyroiditis, Hashimoto's disease, although they're thought of as opposites, they're actually much closer entwined than most people and a lot of physicians know, that there can be an admixture of both Hashimoto's and Graves' in the same patient. And when they're really intertwined, we call this hashitoxicosis. So they're really different manifestations of an autoimmune process within the thyroid gland. Transiently, thyroiditis, or an inflammation of the thyroid, can lead to a hypothyroid state. And this not uncommonly happens after delivery. Somewhere around 15% of patients women after delivery will have an autoimmune process in the thyroid. This is known as postpartum thyroiditis. Iatrogenic. Post-treatment for hyperthyroidism with radioactive iodine or surgery, of course, that's the expected therapeutic outcome. Post-treatment for thyroid cancer, the usual operation is a total thyroidectomy, render the patient hypothyroid because of this. And transiently, high doses of iodine will lead to hypothyroidism, especially in patients who have chronic autoimmune thyroiditis. This is known as the Wolff-Chaikoff effect. That high doses of iodine will inhibit the thyroperoxidase and lead to hypothyroidism that lasts a couple days. This does not happen after you go to your local sushi bar. So don't have to worry about that. It happens after really high doses of iodine, such as are given with the CT angiogram or coronary angiogram. And so you'll see that in some hospitalized patients. Treatment of hypothyroidism. The oldest form of treatment was to use thyroid extract, which is desiccated pig thyroid, basically dried pig thyroid gland. And the dried pig thyroid gland contains T4, it contains T3, and a lot of schmutz basically the schmutz is iodinated tyrosine molecules that have no metabolic effect. The company that first brought it to market and actually continues to market the product after 100 years are the same people that brought you Armour Franks. It's known as Armour Thyroid. So Armour Thyroid, pig thyroid, Armour Franks. Philip Danford Armour, the head of the Armour Company, one of the robber barons of the late 19th century, famously said, the only part of the pig we don't use is the squeal. Thyroxine is the preferred thyroid hormone replacement product. It's the preferred therapy. Triiodothyronine, or T3, is often used as an adjunct to T4 therapy, either alone or in a fixed combination combined with T4. And here's the pharmacokinetics of T4 and T3, which really plays into the physiology that we talked about on Friday. GI absorption of T4 is about 80%. T3 is 100%. But importantly, the half-time in the circulation is very much attenuated for T3 because of its looser protein binding. And it turns over very quickly. The half-time in circulation for T3 is about a day, whereas for T4, it's a week. So T4 hangs around for a long time. And this leads to very small fluctuations in serum levels of T4, but rather rapid fluctuations in the serum levels for T3. Here's a matchup, head-to-head comparison. Thyroid extract is inexpensive, it's natural, but it does have it's tougher to deal with imprecise dosing. Thyroxine is the preferred replacement therapy. The serum levels are constant because of the long half-life. You monitor the patient by thyroid-stimulating hormone levels. TSH is the preferred screening test, the first-line screening test for thyroid disorders, and it's also the way you monitor thyroid replacement therapy is measuring the TSH. If the pituitary is happy, you should be a happy doctor. And thyroxine is converted to T3 in peripheral tissues by the type 1 and type 2 iodothyronine dehydrogenases. So T3 levels are physiologic in patients who have no thyroid secretion of thyroid hormone and are taking T3 alone. As far as T3 goes, the serum levels are very variable because of the looser protein binding. Remember this, T4 levels are low. Any patient who takes triiodothyronine will have a suppressed TSH and decreased thyroid hormone production rates, so T4 levels sink. Any one of us who took T3 in doses enough to suppress our TSH will have a low serum T4 because of decrease in thyroid hormone production rates. In fact, last night, I got back from a 3-day weekend. I checked my email, and I got a very desperate email from a very prominent New York physician at NYU who sent me a case of a patient of his who was taking triiodothyronine and had a low T4 level. And he was wondering, what do I do? What's wrong with this patient? Should I increase the dose? I emailed him back. His TSH is perfect. He's fine. So don't worry about it. And because you can't rely on T4 levels, you monitor TSH for adequacy of replacement. Now, T3 used as an adjunct to T4 is often used to increase the patient's sense of well-being. And there is some literature that it does do that But these have not been blinded studies, and the double-blind, placebo-controlled studies have not shown any improvement in the patient's sense of well-being when T3 is added to T4. So if the patient doesn't know what they're getting, the physician doesn't know what she's giving the patient, no, you don't get any increased sense of well-being. You monitor thyroid hormone replacement therapy by assessing the response clinically for the signs and symptoms of hypothyroidism, and biochemically by measuring TSH levels 4 to 6 weeks after adjustment of the thyroid hormone dosage. And one waits 4 to 6 weeks to allow the pituitary gland to achieve a new equilibrium. The pituitary doesn't turn on a dime. It'll take upwards to 6 weeks before you get a new equilibrium. And if the TSH level is still not optimal, then you bump the dose up a little bit higher. And at the end, the TSH should be within the normal range, preferably within the lower 1/2 of the normal range. And if you are successful, this is what happens. This is our hypothyroid lady who, after 6 months, much less puffy, much brighter, and very happy. Thank you.
Message to mute.
Yeah.
You got it.
Yeah. Can you see it? Yeah.
Thank you.
Thank you very much. Pleasure.
I like my kukla. You always put me after McConnell, huh, to make me look bad. That's going to be my opening line, actually.
Well, your talk actually logically proceeds.
Yeah.
I'll save to a desktop too.
Is there a pointer?
Yes. And do you have Anjali's talk on there too?
No. I emailed her like at least a month ago, never heard back from her.
No. She emailed me saying, I'll see you Tuesday. There's another talk that goes in the middle of his. Oh, okay. Yeah. She'll be.
Usually we just segue. I'll just step down. She can upload her.
Okay.
I don't,
fine.
whatever.
I mean, there's a couple more minutes.
Can you throw this in the pocket? When you're ready, just flip the switch and
This bag is fine?
Yeah, whichever is comfortable for you.
Okay. Sure.
You don't have to wear your white clothes if you don't want to.
I was gonna wear a jacket to look really professional. I'm really.
You even own a jacket?
I own a couple of suits even. How do you advance this arrow?
Yes, so you go back with this one. Forward
Yeah.
with that one. It happened a couple of times with Dr. McConnell that he accidentally hit some of these buttons, so if the display goes blank, this one probably got hit, and we just hit this one to turn it back on.
Okay. I won't remember that, but we'll do our best.
I'll run down.
You're working with a very limited individual here. Sort of just peed in my pants. Had like a little leakage. It's not on. I didn't turn it on. Oh. I don't care. Really? I timed this. It's pretty fast. It's only like 30 minutes max. Can you hear me? All right, I think we're going to get started. Dr. Kerr is motioning to me to get started, so she's the boss. Can everyone hear me? Good. So I'm John Osceola. I'm one of the general endocrinologists who focuses a fair amount on thyroid disease. So Dr. Kerr has asked me to talk about thyroid goiters, nodules, thyroid cancer. She claims this logically follows Dr. McConnell's talk. The major reason she has me speak now is to embarrass me since I have to follow Dr. McConnell. But I'll do my best. So she asked me to add conflict of interest this year. This is my lame attempt at a joke, but the truth is I really have none. I guess I wish I did, because I might actually be making more money. But alas, I don't. Teaching objectives. So this talk we're going to go over three major topics. First, what are goiters? Specifically, we'll review how they are classified, touch upon how and why they may occur. We'll talk about how we evaluate goiters, of course clinically as well as radiographically. And then we'll finish by how we treat goiters, both benign as well as malignant. So first I wanted to start with a few basic slides to get some terminology out of the way. So what is a goiter? You've probably all heard this term at some point in your life, but a goiter is really simply a term for any enlargement of the thyroid gland. And there's three major ways we can classify goiters. First is anatomically. So goiters can be diffuse. This is when the entire or vast majority of the thyroid gland itself is enlarged. And this can evolve into a nodular goiter, and nodular, therefore, is the second way we can anatomically classify goiters. And this is when you develop isolated or multiple growths within the thyroid itself. Secondly, we can classify goiters by their functional status. So there are non-toxic goiters, which will be the major focus of this discussion. These are goiters that do not cause hyperthyroidism in the patient. Conversely, there are toxic goiters, which I'll only briefly touch upon, and these can lead to hyperthyroidism. I know that Dr. McConnell just gave you an overview of hypo and hyperthyroidism, so I'm going to defer further discussion, for the most part, about toxic nodular goiters. And finally, we can classify goiters pathologically. Although I will comment, this is a slight change in the slides you have. I should note this is specific to nodular goiters themselves. So they can obviously either be benign or malignant. Fortunately, the vast majority are benign. Studies suggest somewhere around 90 to 95% of all nodules are benign. Therefore, about 5 to at most 10% are malignant. Okay, so how does a goiter form? Well, first, and I think Dr. McConnell covered this in great detail, but just to remind you that in normal thyroid tissue, TSH, the thyroid-stimulating hormone secreted by the pituitary, regulates both cellular growth and differentiation in the thyroid gland. So how does a diffuse goiter develop? There are likely extrathyroidal growth factors, either TSH itself or less commonly in something like Graves' disease, where you can have TSI, which is an abnormal antibody. These extrathyroidal growth factors stimulate cell growth, and the cells therefore get larger, they become hyperplastic, and you can develop a goiter. Likely there are genetic mutations involved in individuals who are at risk for this that lead to an increased sensitivity to TSH itself, and there may well be goitrogenic substances. These are any substances found in the environment that impair thyroid hormone synthesis. They're also likely involved that make patients susceptible to hyperplasia of the thyroid. Nodular goiters are a little bit different. It's likely that first the cells are hyperplastic, and over time these cells involute and fibrose and can lead to nodular development. Fortunately, as we already alluded to, malignant transformation of the thyroid cells is uncommon, but certainly possible and something that we need to be mindful of. Okay, so I wanted to review again in detail what mostly non-toxic goiters. So what is a non-toxic goiter? So it's a goiter, so it's an enlarged thyroid, and it's non-toxic, so therefore it does not lead to hyperthyroidism. Specifically, that means that the TSH will be normal or even elevated, because patients could be hypothyroid, and they'll have no signs or symptoms of overt hyperthyroidism. Anatomically, non-toxic goiters can be diffuse or nodular. And what are some examples of non-toxic goiters? There's 5 major categories. The first is simple goiter, and this is any thyroid enlargement not caused by inflammation or neoplasm. Secondly, chronic lymphocytic thyroiditis, commonly referred to Hashimoto's thyroiditis. I have a slide coming up. We'll talk about Hashimoto's in more detail. It's a very common cause of an enlarged thyroid in this country. Thirdly, you can have infiltrative processes that involve the thyroid, of course cancer being one of them, but there are other disease processes that can infiltrate the thyroid and lead to an enlarged thyroid. The last 2 we really won't spend any more time on, but there are congenital goiters, and occasionally there's a physiological goiter during puberty that usually resolves. Okay, so what are simple goiters? There's actually 2 types of simple goiter. The first one are endemic, and this is simply defined as goiters that have an increased prevalence in a predefined geographic area. Very specifically, it's defined as goiters that involve greater than 10% of all school children in that area, or greater than 5% of the total population. Worldwide, this is the most common, by far, form of goiter, and the vast majority of the cases are due to iodine deficiency. I think you just learned from Dr. McConnell that iodine is central to formation of thyroid hormone, right? So if you're deficient, it can lead to low T4 and T3 levels, which in turn will stimulate the pituitary gland to make more TSH. As we just discussed, TSH in turn can make thyroid cells grow and can lead to goiters. Just as an aside, the recommended daily iodine intake is 150 micrograms. In the early 1900s in the United States, we began to add iodine to our salt supply, and we've essentially eradicated iodine deficiency in this country. And this just shows you, actually pretty much in all of North America, there's really no iodine deficiency. Unfortunately, there are parts of the world where there's still severe iodine deficiency. Ironically, in this country, there have been occasional outbreaks, if you will, of iodine deficiency, and it's often due to people sort of having fad diets where they don't have normal iodinated salt, and they can end up actually, ironically, iodine deficient. This is an extreme example of iodine deficiency. So again, to walk you through it, iodine deficiency, there's no substrate to form T4 and T3, so you're going to end up eventually with decreased T4 and T3 levels. There's going to be a compensatory response by the pituitary, increases TSH, leads to cellular hyperplasia. Over time, as you can see, there are distinct nodules here, most likely. The hyperplasia leads to nodular development, and you end up, in this example, with an extremely large nodular goiter. Okay. Simple goiters can also be sporadic, and this is much more common in the United States. Sporadic simple goiters are simply goiters arising in iodine-sufficient areas of the world. And anatomically, they can both be diffuse or nodular. The etiology of these goiters is thought to be likely sort of a two-hit process. There's probably, most patients have some type of environmental exposure. Some environmental factors that have been isolated are smoking. Certain drugs can lead to goiters. A major one that we think of is lithium, which is commonly, not uncommon medication used in certain psychiatric conditions. There's also natural goitrogens. So these are substances found in toxins or even certain food metabolites that impair iodine uptake and therefore impair thyroid hormone synthesis, and again can lead to hyperplasia via feedback by the pituitary and increased TSH levels. And lastly, another risk factor is radiation to the head and neck. Secondly, most of these patients likely have a genetic predisposition to forming goiters. So the next common cause of goiters is Hashimoto's thyroiditis, or chronic lymphocytic thyroiditis. This again is diffuse or nodular, and is pretty much always seen in iodine-sufficient areas of the world. It's very common in the United States. It's estimated the prevalence is roughly 3 in 1,000 patients. It's more common in women. It's an autoimmune disease. In fact, autoimmunity in general is more common in women than in men. And specifically what's occurring is you have an infiltration of lymphocytes that leads to inflammation and fibrosis of the thyroid gland, which can then lead to goiter or nodular development. In addition, due to the fact that the thyroid gland itself is being slowly destroyed, it's an insidious disease with slow progression to hypothyroidism. It is interesting, some patients with Hashimoto's are hypothyroid by the time they're 20 years old. Others don't become hypothyroid until they're 80, and some even live to 100 years of age with Hashimoto's and never need thyroid hormones. So it's a variable time course in patients, but on average, it tends to be slowly progressing. And once again, I kick this to go over this. The decreased T4 and T3 stimulates TSH production, which then the chronically either high normal or frankly elevated TSH levels can lead to further enlargement of the thyroid. Okay, lastly, the major classification of goiters we're going to review are nodules themselves. So nodular goiters are extremely common. This is actually probably slightly old data in all honesty, but some prior studies suggest that somewhere around 4 to 6% of patients have not palpable nodules on exam. But we know that they're vastly more common than that based on ultrasound studies as well as autopsy studies. So it's estimated upwards of 50% or more of the population has some form of nodular goiter. Some estimate actually that every decade of life you have an increased 10% chance. So when you're 10 years of age, you have a 10% chance. When you're 50, you have a 50% chance. When you're 80, you have upwards of an 80% chance of having a thyroid nodule. So exceedingly common. They're more common in women, likely due to the increased risk of Hashimoto's, which is a predisposing risk factor for nodules themselves. And as I said, the incidence clearly and significantly increases with age. Fortunately, most nodules that develop are stable both in size and function over time. Again, these are a little bit old studies, but I think they confirm the point. One study showed that over a 10-year period, only about 15% of the nodules assessed increased in size. Another study showed that there was about a 10% incidence of hyperthyroidism over a 12-year period. When hyperthyroidism is developing, it also tends to be an insidious, slow process with a prolonged subclinical hyperthyroid phase. To remind you, subclinical hyperthyroidism is when you have a mildly low or frankly suppressed TSH, but you still have normal T4 and T3 levels. And again, a small percentage of nodules, about 5 to 10%, are in fact malignant. Okay, so how do we evaluate an enlarged thyroid? First and foremost, like everything, there should be an appropriate clinical evaluation. So first, you want to assess for both signs and symptoms of hyperthyroidism. Those might include weight loss, heat intolerance, palpitations. The patient might be tremulous on exam, be tachycardic, have brisk reflexes. Again, I think a lot of this was reviewed by Dr. McConnell, but you want to do a clinical assessment for signs or symptoms of hyperthyroidism. You also want to assess for symptoms of the goiter itself. And to remind you your anatomy, the thyroid sits right on top of two critical entities, your esophagus and your trachea. So if it gets rapidly enlarged, or even if it's slowly enlarged, becomes very, very big, it can compress either one of these structures. Therefore, you need to assess for compressive symptoms, which include shortness of breath, if your trachea is compressed, cough or dysphagia, trouble swallowing, if your esophagus is compressed. In addition, you want to ask for hoarseness or sudden pain, because these can potentially be ominous symptoms. And then lastly, of course, you want to palpate the thyroid gland itself. So is the goiter diffuse or nodular? That will help begin to have you think about the differential. Is there one nodule, or are there multi-nodules? Are the nodules hard, fixed, or tender? This last point leads to the next slide, but some of these factors can be associated with an increased risk for malignancy. So what are cancer risk factors with nodules? Well, first, there are patient characteristics. So male gender is an increased risk factor. This, in the past, I think has confused some students. So women are more at risk for nodules, but if you have an actual nodule that already is there and it's in a male, there's actually an increased risk of cancer because they get fewer nodules. Okay, and age is a risk factor itself. So patients who are less than 20 years of age or greater than 60 years of age with nodules, there's some increased risk for having cancer. And radiation exposure in the patient or family history of thyroid cancer is also a risk factor for cancer. There are certain characteristics of the nodules themselves that increase our concern for the presence of cancer, and these are nodules that are firm or fixed and or ones that have rapid growth. Particularly the latter can be potentially very concerning. And lastly, clinical characteristics. So does the patient have new onset of hoarseness or vocal cord paralysis? Again, these are just secondary to the anatomical location of the thyroid, and if there's rapid growth, it can affect surrounding structures. And is there regional lymphadenopathy? So in the rest of the anterior neck, can you palpate any enlarged nodes? That can be of some concern. So how do we further evaluate patients beyond the clinical setting? Well, you want to check laboratory values on every single patient, particularly at TSH level. As we just discussed, you're going to assess clinically for the presence of hyperthyroidism, but occasionally patients will mask a lot of signs or symptoms. So you want to just make sure you check a TSH on every single patient to rule out a toxic goiter. The major reason there is the way we treat it is completely differently, and furthermore, toxic goiter, nodules that are leading to hyperthyroidism are almost never cancer. So from a cancer perspective, it's actually a good sign. In addition to laboratory testing, virtually all patients will have some type of imaging modality far and away, the most important is ultrasound. It's the most common and by far the best form of imaging the thyroid, and we'll spend the next few slides discussing that in greater detail. Slightly less commonly, but still relatively commonly, we might do a radioactive iodine scan, which we'll also talk about briefly. And I suspect Dr. McConnell touched on that as well. Lastly, occasionally, but far less commonly, we need to use CAT scans to better define the neck anatomy, or even a PET scan. Lastly, we also may need to do a fine needle aspiration biopsy. Because nodules are so common and they're also much more likely to be benign, we certainly do not biopsy every single nodule. And towards the end of the lecture, we'll go over an algorithm that helps us sort of decide which nodules we biopsy and which ones we don't. So a few slides on ultrasound, because this is a very important modality. So it's by far, as I said, the most important imaging modality for nodular goiter. And the reason is it provides high-resolution imaging of the thyroid. That allows you to estimate the size of the gland as well as to determine whether, in fact, nodules are present. You're going to examine every thyroid gland, but particularly early on, you're going to miss nodules. I've been doing this for a few years, and I clearly miss nodules on exam. Ultrasound will help detect any nodules that you might miss on exam. Furthermore, it helps distinguish between solid and cystic nodules. Purely 100% cystic nodules are virtually never cancerous, so that's a reassuring sign, even if they're quite large. It also helps by other features to potentially distinguish between benign and malignant nodules. And lastly, when needed, it helps provide guidance for fine needle biopsies. In addition to being extremely useful, equally as important is there's no ionizing radiation with ultrasound, so it's an extremely safe modality for the patient. Okay, so this is just a slide going over a basic ultrasound. Here is this large black area is the trachea to orient you. In the middle here is the isthmus gland of the thyroid. And then here you see this is the entire right lobe of the thyroid. And over here is your left lobe. Okay, and just to orient you, here is your left carotid. And over here would be your right carotid. Now tucked within the right lobe, as you can see, here is a nodule. And this is what we call a hypoechoic nodule. It's a fancy word. It simply means that it projects less brightly than the surrounding thyroid tissue. Okay, so I've already alluded to this, but there are multiple features on ultrasound that help guide our thinking as to whether a nodule is benign versus malignant. I will say up front, however, while someday we hope that ultrasound can replace biopsies, we are not there yet. These are guides, but if you have any uncertainty, you always have to biopsy. And ultrasound can never tell you with the same accuracy as a biopsy whether a nodule is benign or malignant. Having said that, features more consistent with benign nodules are those that are iso or hypoechoic. So if their brightness is similar or even more bright than the surrounding thyroid tissue, that's a reassuring sign. If you have coarse calcifications, calcifications often show up as bright white spots. If they're large and sort of chunky looking, that actually can be a good sign. If they have a thin, well-defined halo, so many nodules have a small surrounding portion around it called the halo. If you can see that and it's very well defined, that's extremely reassuring. If they have regular margins, that's usually consistent with benign nodules. If you don't see any overt invasive growth, with most ultrasounds, we also examine the entire anterior and lateral neck. So if you don't see any abnormal lymph nodes, that's reassuring. And lastly, the nodules, if they have either a little bit of peripheral or even no vascularity, that can be a good sign. Conversely, the signs consistent with malignancy, as you might imagine, are essentially the opposite. So hypoechoic nodules, the one we just saw, can be concerning for malignancy. Microcalcifications, these are smaller calcifications. Those, in contrast to coarse calcifications, are a concerning finding. A thick, irregular, or even an absent halo is more consistent with malignancy. A nodule with clearly irregular margins is of concern. Those that are already showing invasive growth, this is often a little harder to see, or if you see abnormal lymph nodes on exam, or if they have increased vascularity, particularly peripherally, excuse me. Anyway, I got a new phone. I don't know how it works. Um, all right, so these are just some quick slides to review what we discussed. This is a halo sign. This is a large nodule, so truthfully you may end up biopsying it anyway because of its size, but the halo, as you can see, is a thin surrounding portion of the nodule. That's a very reassuring sign. These are microcalcifications. I think you need to look at a lot of ultrasounds to learn how to distinguish micro from coarse. I sometimes still struggle with it. I often have ask my colleagues their thoughts, but this is an example of microcalcifications, these white spots. You can also, you might imagine too, here the nodule is a little bit irregular. This is a nodule you would want to biopsy. This shows increased vascularity of note, particularly internally, which can be a concerning sign for malignancy. Okay, the other second most important form of imaging to assess an enlarged thyroid is a thyroid scan. And what this does is measures radioactive iodine uptake in the thyroid. So as we know, iodine is the major substrate for thyroid hormone synthesis. So the thyroid needs to take up iodine. So we take advantage of that by giving patients radioactive iodine pills. They swallow the pill, and then the next day they come back and have pictures taken of their thyroid gland. This is done for two primary reasons. One is to assess the uptake of radioactive iodine in the thyroid to help distinguish certain causes of hyperthyroidism. I suspect Dr. McConnell went over that, or will be discussed in future lectures, but briefly, hyperthyroidism due to either a toxic goiter or a Graves will have significantly increased radioactive iodine uptake. If it's due to a thyroiditis where there's acute destruction of the thyroid gland, radioactive iodine uptake will be significantly decreased. Secondly, though, radioactive iodine scans can be used to assess the functionality of a thyroid nodule itself. So in this example here, this is a normal uptake. So all the white here is showing you the uptake of radioactive iodine in the thyroid. Over here you can see, while this lobe is very normal, there's a large area here where there's no iodine uptake. This likely represents a large nodule where there's no iodine uptake. We refer to this as a cold nodule. And cold nodules carry the risk of malignancy. So if this nodule otherwise met criteria on ultrasound or was large enough, you certainly would want to biopsy it. Conversely, you can identify functional thyroid nodules on an uptake scan. And these are called hot nodules. So here is a large nodule in this lobe that's having increased iodine uptake. And this can, an uptake scan can sometimes reveal either single or multiple hot nodules. So these are nodules, again, that have increased iodine uptake. Therefore, they're likely going to lead to hyperthyroidism in the patient. They're quote-unquote functional nodules. The good news, however, is that the risk of malignancy in hot nodules is very low. All right, at this point, I'm going to turn it over for a discussion of pathology, and then when I come back, we'll resume with discussion of treatment.
It's under folder. Going down. Let's do it. This one? Yeah, the second one. Yep, no, sorry, 426. Direction is pulled out. Should I just pull out the noise? Or it's on? I can wait too.
So my name is Dr. Oh, actually I should turn this on. Can everyone hear me now? Okay. My name is Dr. Anjali Saki. I practice pathology. I do both surgical pathology and cytopathology. And basically the difference is, as Dr. Ausiello referred to, when we do fine needle aspirations, that's something that's done by a cytopathologist. And rather than looking at big pieces of tissue, a small needle is placed in a nodule, and we examine the cells, we make a smear of it. So that's cytopathology. And anything that's tissue, other than using a tiny needle to aspirate just cells, that's surgical pathology. So just to go over some of these things. First, before I go into the thyroid cancers and other diseases, I just want to show you normal anatomy, which you're probably familiar with, but we can just review it quickly. So this is what the normal thyroid gland looks like. And usually normal thyroid tissue has these follicles. And most of these follicles, they're typically large in size. The pink material here is called colloid, and these are follicular cells that surround the follicles. And if you look at most of these follicular cells, they tend to be very tiny. They're about the size of lymphocytes. And this is what you normally see in a thyroid gland. And often we see these like little bit fibrous areas. And these fibrous areas or septa basically separate the lobules of the normal thyroid gland. And this is normal architecture. And again, this just highlights the follicles. So there are a few different neoplasms that can occur in the thyroid. One is a follicular adenoma, which is a benign neoplasm. And then there are thyroid carcinomas. So first I'll go over a benign neoplasm. This is follicular adenoma. And then I'll go over the carcinoma. So what is a follicular adenoma, and how does it differ from a normal thyroid gland? So if you look at, first I'll go over the morphology here. This is a septa here. This would be normal thyroid because it has large follicles. In contrast, when you look at these follicles, they're much smaller. So whenever you see these tiny follicles, one of the things in the differential is basically, is this an adenoma, and I'll go over, could it be carcinoma? And the way you distinguish this is often follicular adenomas are solitary, but they can be multiple. And follicular adenomas typically have this fibrous capsule that separates the normal thyroid from the adjacent neoplastic thyroid. And basically, when we see this morphology, we call it a follicular adenoma. And the other key factor is the outside looks different from the inside. And these tend to be mostly made out of microfollicles, but occasionally they can have larger follicles, some of which may resemble normal thyroid. But the difference is it's got this capsule, it's well-encapsulated nodule, and that's how you make the distinction. And again, this just highlights the normal microfollicle. So what about thyroid carcinoma? And it's relatively low, as we mentioned, and that there are several risk factors that can contribute to thyroid carcinoma. The most common of all the thyroid carcinomas is papillary thyroid carcinoma. This is followed by follicular carcinoma, anaplastic, and then medullary thyroid carcinoma. And papillary thyroid carcinomas, these are often the carcinomas that are associated with the calcifications that were just alluded to before. So the first carcinoma we're going to discuss is the most common one, which is papillary carcinoma. It can occur mostly at any age. We find single nodules, but we can also find multiple nodules and bilateral disease. And sometimes we find papillary carcinomas incidentally. It could just be a 1 millimeter focus of papillary carcinoma in a thyroid that was otherwise taken out for, let's say, a very large nodular goiter. In addition to it being multifocal or solitary, there are few key features for papillary carcinoma, and most of this is a little bit of the architecture, but mostly the nuclear features. So we talked about follicular adenoma. It's really the architecture I'm looking at. Over here, you can have a certain architecture, but basically the nuclear features are what we really want to focus on. And one of the main things is the nuclei have very fine chromatin. And often, for those of you who remember, it looks like orphan Annie nuclei, and I'll point that out. The second thing is these cells can often be associated with pseudo-inclusion. So what basically happens is the nuclear membrane kind of invaginates inside the nucleus and forms a little circle, and that's called a pseudo-inclusion. the nuclear membrane can also just have a fold through it, so that's called a nuclear groove. So these are key features that you really want to look for. And often if you come across a question or a report and they say they found Samoma bodies, basically whenever you find Samoma bodies, this is associated with papillary thyroid carcinoma, not one of the other carcinomas. And just as an aside, Samoma bodies, they're not unique to papillary thyroid carcinomas. They can be seen in other tumors that have a papillary architecture. And finally, usually patients have a very good prognosis, especially if they're detected early. So what does papillary thyroid carcinoma look like? So these are the nuclear features that I want to point out. So first, actually, before I get to the nuclear features, if you look at the architecture here, there's a core of tissue. All of these are cores of tissue, and they're surrounded by cells. And these are papillae. So basically, it's just like finger-like projections surrounded by cells, and that's what makes it papillary. And the reason I mentioned that architecture is important, but it's not always the case, because sometimes you have a follicular architecture, the round circles, and it's surrounded by these type of nuclei. So you don't always have to see papillae, but whether you see papillae or you don't see papillae, you can still have papillary carcinoma. And the key features are the nuclei. And if you look here, you see these are what's referred to as orphan antinuclei. You get this clearing of the nuclei. It's not always seen in all of the cells, but it can be seen in some. And this is basically a fixation artifact. And some of the other features that we can see here, the nuclei are elongated, and you can see these lines running through it. These are called the grooves. And in addition, this would be a pseudo-inclusion. This is where the nuclear membrane folds inside and forms these circles. And again, these are the grooves. And these two are cytology preparations, and these two here are surgical pathology. And again, I want to highlight that this core in the center is the fibrovascular core, and it's lined by cells that are atypical. In a follicular adenoma or follicular carcinoma, you're not going to see these nuclear features. So that's really the feature that helps us make a distinction between papillary carcinoma and a follicular lesion. The second most common carcinoma that we see is a follicular carcinoma. And this actually appears morphologically very similar to the follicular adenoma that I showed. But the difference is two things. One, in contrast to a follicular adenoma, it has to have vascular invasion and or capsular invasion. So if you have what you think looks like a follicular adenoma, but then you see either vascular or capsular invasion, then the diagnosis is a follicular carcinoma, not a follicular adenoma. So let's look at a couple examples of this. So over here, we have relatively normal thyroid because it's got these larger follicles. Here is the capsule that's separating the lesion from the normal thyroid. And you can see that these small microfollicles are going through this capsule, and this is capsular invasion, and this is what makes it carcinoma. Here is another area, and again, you have the neoplastic cells, normal cells, you have a capsule, and then there is a tumor going through this. This, again, is neoplastic cells. Out here would be the normal thyroid, and this is a vascular space, and you have these cells going into this endothelial spaces. So this is what makes it a follicular carcinoma. You can have either one of these, or you can have both. And the last thing, I'm not going to go into detail, but another type of carcinoma you're going to hear about is called a Hürthle cell carcinoma. The difference between a Hürthle cell carcinoma and a follicular carcinoma is just the cells. In contrast to these cells, the Hürthle cells have more abundant eosinophilic granular cytoplasm, and they often have these prominent nucleoli, so this is what makes them Hürthle cells. But if the same cells were here, and then they go into the vessels, that counts as Hürthle cell carcinoma. If they go through the capsule, then they may also make it a Hürthle cell carcinoma. And similarly, if you have just Hürthle cells all confined within a capsule, it's a Hürthle cell adenoma. So it's the same thing, it's just that the cells look different. And this just highlights the small and large areas, the capsular invasion, and the vascular invasion. So the next type of carcinoma that is very aggressive and we don't see too often, it's an anaplastic or undifferentiated type of carcinoma. And these carcinomas are sometimes can be a little bit of a medical emergency because patients often present with compressive symptoms. They may have difficulty breathing, swallowing, hoarseness, and then we often think about this type of carcinoma. And in contrast to the follicular carcinomas and the papillary carcinomas, the cells in these tumors look very pleomorphic. They can be, so you see they're not nice and round. Oops. They're not very nice and round. They're very, they have a lot of atypical contours, atypical mitotic figures, and this is when you think about anaplastic thyroid carcinomas. And basically, it's the morphology that makes the distinction. That's how we make the diagnosis. And in addition, sometimes you can find residual papillary carcinoma in the background. You can find residual follicular carcinoma, papillary carcinoma. Either one of those can occur alongside this. So, you know, the theory is probably the native papillary or follicular carcinoma just, you know, took a bad, has a very aggressive course, and it turned into this. So the last type of carcinoma I'm going to discuss is a medullary carcinoma. And the reason this is sort of interesting is because most of these cases are sporadic. Some of these can be associated with MEN2A or 2B. The sporadic cases usually occur in older patients, and if you present at a younger age, it's often familial. And these have a unique morphology because they appear very monomorphic and they're neuroendocrine appearing. So if you look at these cells, they're very nice and round, kind of like what you would see in a follicular adenoma or a follicular carcinoma. But the cells in these have very fine chromatin, and which is typical of neuroendocrine neoplasms anywhere in the body. So when you see that fine chromatin, very monomorphic appearance, where every cell looks almost the same, think about medullary carcinoma. These cells also stain with neuroendocrine markers. So how do we make a diagnosis? You know, as Dr. Ausiello discussed, you know, there are different ways to determine if something is benign, malignant, or not. And one of the things that's often done is a fine needle aspirate. You take a tiny needle, place it in the nodule, we make a smear, and make a diagnosis. The advantage of this is you don't actually have to take someone to surgery, and most of these nodules are benign, so you really want to triage up front if someone has a malignant nodule or not. There are occasionally false positive rates, but they're relatively low, and there are some false negative rates. So most recently, maybe within the past few years, there's been a system for diagnosis. We use the Bethesda thyroid guidelines, and basically it goes from 0 to 6, and you know, the lower the number, the most likely something is benign, and 6 would be malignant. That's
Sorry, I realized I closed all your slides by accident.
Do you remember what slide you were on?
Yeah.
Okay.
Oh, it's not projecting. So in the remaining few minutes, we're just going to talk about treatment of the goiters. So again, it's going to depend on what type of goiter we're dealing with. Probably the most straightforward would be your endemic simple goiters. Most of these, to remind you, are due to iodine deficiency. So the way we treat it is to give patients back iodine. And from a societal perspective, we can do what we did in this country over 100 years ago, is supplement the food supply with iodine, so it becomes extremely unlikely that patients going forward will become iodine deficient. There are other forms of endemic orders, and in those cases, you just also have to try to remove whatever goitrogens are causing the enlarged thyroid. So for sporadic goiters, it gets more complicated. First, we'll take the example of a diffuse goiter. In the past, actually, certainly before I was practicing, we used to give thyroid hormone. And giving thyroid hormone actually will decrease the size of a diffuse goiter, somewhere around 15 to 40%. Unfortunately, however, it's more effective with increased suppression of TSH. So that means you're putting patients at increased risk for hyperthyroidism. Furthermore, once you stop thyroid hormone, growth usually will return. Because of this, we actually don't do this anymore. So you would be putting a lot of euthyroid patients on thyroid hormone and potentially rendering them hyperthyroid, and you would have to do it potentially for life, since once you stop, the growth will return. So for most diffusely enlarged thyroid glands, we leave them alone because they're probably not hurting the patient anyway. Okay, what about nodular goiters? So it depends. First, we'll go over a algorithm for uninodular goiters. And I will say this, this is just one approach. I think it's a relatively common approach, but there are different ways to do this. But for a patient with a solitary nodule, what we tend to do here is, if it's small, we used to define that as less than a centimeter. We're moving more and more towards defining that as less than 1.5 centimeters. Or if there are extremely non-concerning features on ultrasound, then we'll often just observe these nodules. And what we mean by observe is we won't forget about them. We'll follow them with serial ultrasounds, and if things are changing, we might reconsider, but we won't biopsy them. However, if they're larger, again, somewhere around now 1.5 centimeters or larger, or if they're maybe a little smaller, but they have extremely concerning features on ultrasound, then we'll usually proceed with a biopsy. If the biopsy is positive, then we'll have to, patients typically go to surgery. If it's negative, again, we'll follow with serial ultrasounds. So surgery is indicated for a single nodule if you have a definitive concerning pathology on FNA, or if the patient has symptoms, compressive symptoms, so if they have shortness of breath or dysphagia that you really think is from an enlarged thyroid, then you might consider surgery. The least common cause, but it does occasionally occur, some patients will go to surgery for cosmetic reasons. Multinodular goiters are even more complex. I've had patients who've had upwards of 10 plus nodules on ultrasound, and it can get a little tricky figuring out what to do with each individual nodule. So a relatively common approach is to biopsy the quote-unquote dominant nodule, or any of those that meet criteria based on their ultrasound appearance, generally focusing on, again, size and their overall appearance. Once again, similar algorithm. If you biopsy them and they're benign, you continue to follow them. Usually with the early ultrasounds initially. In rare circumstances, if you're particularly concerned, because there is a false negative rate for biopsies, you might repeat the ultrasound in 6 months. The idea, of course, is benign growths will stay roughly the same size or completely the same size, while malignancies will tend to grow. And furthermore, with thyroid cancer, it's a relatively slow-growing cancer, so you often have time to make this diagnosis. Occasionally, we'll use radioactive iodine to shrink nodules, but in non-toxic multinodular goiters, this is very uncommonly done. I've, in fact, never done this. But in theory, radioactive iodine could decrease the size of a non-toxic multinodular goiter. Similar to the uninodular algorithm, for multinodular goiters, surgery is typically reserved for a positive biopsy for patients with clear symptoms or for cosmetic reasons. This is a little bit of an overview of a similar idea here. So you have a patient, you palpate a nodule, you'll undergo the clinical evaluation as we've discussed. You definitely want to get an ultrasound to confirm your exam as well as to identify potential additional nodules. And then you want to check also a TSH level. So first, we'll say if the TSH, if we go over here, if the TSH is suppressed, remember they're at risk for, they may be overtly hyperthyroid or have subclinical. You want to pursue a thyroid scan. And if you identify a hot nodule, these are almost never malignant. So you don't have to biopsy this. However, you still have a nodule, or maybe multiple nodules, that could lead to hyperthyroidism. So typically those will, if they're causing clinical symptoms, they may be treated with radioactive iodine to destroy the thyroid or to have them surgically removed. Conversely, if your TSH is normal, or if you had a suppressed TSH but a cold nodule on thyroid scan, we move over here and we'll biopsy the nodule if criteria up here indicate. So if the ultrasound's concerning, etc. If the FNA is benign, we'll typically observe with serial ultrasounds. Occasionally we'll still go to surgery, as we discussed, if the nodule is very large and causing symptoms or cosmetic concerns. If the biopsy is malignant, clearly, with rare exceptions, the patient will undergo surgery. If it's suspicious, as was alluded to, we used a Bethesda scale 0 to 6, with some of those being indeterminate. It's a decision that the provider and patient need to make, but occasionally we'll pursue surgery if the FNA is indeterminate. Okay. What about radioactive iodine ablation? So this is a little bit different than a radioactive iodine scan. We use a different isotope. This is I-131, and we use this primarily to treat toxic nodules or multinodular goiter. Rarely it's used for non-toxic goiters. It takes advantage of the thyroid avidity for iodine, so the patient swallows the pill, the iodine gets taken up in the thyroid, and then the radioactivity slowly destroys the thyroid gland. If you are using it to treat a non-toxic multinodular goiter, it's again used to treat an overactive gland or uncommonly non-toxic. In the case of a non-toxic multinodular goiter, it can lead to hypothyroidism. In cases of a toxic multinodular goiter, we actually typically will treat intentionally to try to induce hypothyroidism. So we'll give a big dose with the hope that enough of the thyroid gland will be destroyed and the patient will be rendered hypothyroid. So what about surgery? We've covered a lot of this, but again, the reasons for surgery most commonly is due to a positive biopsy. Slightly less commonly, but sometimes you'll need to do a rapid decompression of vital structures due to acute symptoms. Sometimes you need to go to surgery, unfortunately, to get a more definitive pathological sample. If the FNA was indeterminate and you're concerned, then you might take the patient to surgery. Hyperthyroids or toxic multinodular goiters, they often can't be cured in any other way, so sometimes it results in surgery. And again, the least common reason is for cosmetics. There's a couple of different types of surgery. The most common is a total thyroidectomy. It's, as the name implies, the entire thyroid gland is removed. Occasionally there'll be a subtotal or even a hemithyroidectomy where only one side of the thyroid gland is removed. There are, as with every surgery, some risks. The major ones, fortunately, are relatively low, so mortality is well less than 1%, particularly if you're in the hands of a good surgeon. Recurrent laryngeal nerve injury, so the laryngeal nerve runs through the area of the neck where the thyroid is, so surgery there clearly could damage it. This is a relatively dreaded outcome. Fortunately, it's rare because it can lead to permanent hoarseness. Hypoparathyroidism can occur. You'll learn more about the parathyroid glands later in the course, but four of them, they sit in and around the thyroid, and they can be damaged during surgery and lead to either transient or permanent hypoparathyroidism. And then hypothyroidism, of course, if you have a total thyroidectomy, you certainly hope the patient's hypothyroid or something went wrong in the surgery. But occasionally, if a hemithyroidectomy is performed, they may actually remain euthyroid. So treatment of thyroid cancer, this could be a discussion unto itself, but very briefly, the mainstay for most thyroid cancers, of course, is surgery, specifically for papillary, follicular, and medullary thyroid cancer. Unfortunately, for the one type of thyroid cancer that really is quite deadly, anaplastic surgery typically is not very effective. Total thyroidectomies are usually performed. Sometimes if you have a relatively small nodule on ultrasound on one side with a positive biopsy, completely clean thyroid lobe on the other side, you may decide to do a hemithyroidectomy, and you may not need to go back in and remove the other gland, depending on what the pathology results show. And then sometimes after surgery, we'll use radioactive iodine. There's two different ways we do this. Most commonly, it may be done with what we call ablation. This is typically done somewhere around 6 to 8 weeks, or maybe a little bit longer after the surgery. And the idea, it's based on how concerned you are about the pathology. If it's somewhat concerning or very concerning, we'll give a dose of radioactive iodine. And the idea is to ablate any remaining thyroid cancer cells plus normal thyroid cells that were left behind from the surgery. And the reason we do this is first, of course, to get rid of any additional cancer cells, but secondly, it allows for follow-up to be a little bit easier if there's also no healthy thyroid cells left. We also sometimes give radioactive iodine in quote-unquote treatment doses. This is typically later on, a year, or sometimes many years later. If there's evidence for metastatic disease, we'll give a higher dose of radioactive iodine. Finally, for both papillary and follicular cancer, we'll treat. They've had surgery, so they almost always need thyroid hormone, but we intentionally treat in all but the lowest risk cancers to render the patient mildly hyperthyroid, because we want the TSH as low as we can get it without them being adversely affected, because that will suppress cancer cell growth. That's it. Thank you. Oh, I guess any question?
Can you switch it to me?
What?